Good evening, everybody, and welcome to the first ever Voices That Heal podcast for the Heal Collaborative. I'm so excited to be with you tonight. This is your girl, Jamie, aka Jams. You may have seen me from some other previous recordings, things like that, but I'm very, very excited to be a part of this effort here. This is the first of the podcast series that we're going to be doing on a monthly basis, where we bring in special guests and subject matter experts in the lung cancer field to talk through some of the things that we as cancer patients and advocates and survivors deal with on a regular basis, but don't always get the opportunity to talk to those people in the fields about. Whether we're sitting in at conferences or whether we're attending events, these folks are on the stage, they're doing their conversations, but rarely do we get to interact in the way that we're going to be bringing them to you this evening. So tonight, I'm very excited to bring Miss Dana Thomas with us tonight. She is from Grady Memorial Hospital in Atlanta, Georgia. She's a nurse practitioner, and she is, some would call you, a subject matter expert in the lung cancer screening field. So I figure there is nobody more qualified to have this conversation, if you would, than yourself. So Dana, welcome to the show, and how you doing tonight?
Thank you for having me. I'm so excited. It is important to have these conversations because I know there's still a lot of questions, a lot of people that are scared to go, get their screening done. So I'm always open to talk about screening and get more people involved.
Absolutely. And so I guess give us a little bit of your background, how you got involved with Grady, and more importantly, what drew you to the lung cancer, realm, if you will. There's a lot of other areas where you could be a nurse practitioner, but you chose this specialty. So why lung cancer? And give us a little bit of your background.
So as a nurse, I worked in surgical oncology. So a lot of patients that were going through different surgical treatments for breast cancer, colon cancer, pancreatic cancer. So a little bit of everything. So I got to see a lot of different cancers, but it was primarily the surgical aspect of it. So after I went back to school to get my master's, started looking for a job, wasn't too sure what I wanted to do. I know I liked oncology, but I also liked surgery, so I ended up taking a surgery job for a couple of years. I loved it, but it wasn't fulfilling. I felt like it was just a job. I was doing it, going through the motions, but there was no connection to the job or the patients because it was outpatient surgeries, and it was elective procedures, so it was pretty much just a job. So I heard about Grady needing, they were starting up this program. They want to do a lung nodule clinic. They want to start, do a lung screening program. I heard about Dr. Flanant through one of my close friends, and she was like, you would hit it off. Your personalities would match. He has a big drive. He cares about patients the way you're, confident and want to go out there and speak with different people. So I heard about the job. I applied. So I got into it was new to me. I did have a family member that was diagnosed with lung cancer while I was in nursing school. So it did hit home like, do I want to deal with this? Because I know her journey was not a pleasant one. So it was that aspect. But then on the other side, I also knew how important it was to have that discussion and how often, African Americans are not going for screenings because of misinformation, communication, not distrust in the system. So I know, especially working with another African American, because the doctor that I work with is an African American male. So it does make a difference when they come to see us. It's two African Americans. Our patient population is primarily African American, at least 95 or more percent. So it does make a difference. So I kind of got into the field just by chance. But here I am 7 years later.
Well, we are super grateful to have you in the community for sure. So we need folks that are passionate, and it's nice when folks join because they have the connection to lung cancer, but it sometimes means even more when people just identify and see that there's a need and just want to join the fight as well. And I feel like we have you on both sides. So I definitely appreciate it. As a lung cancer patient myself, just having you in the field and being able to talk to you tonight. For all those folks that are tuning in across the different platforms, we are live on YouTube as well as Facebook. You can drop comments in the chat. They will show up on the side here, and I will ask the questions for you. We will incorporate you right into the conversation. Welcome to everybody tuning in from Florida, Tennessee. We've got folks already all around the United States tuning in, and I'm really excited to see it. So let's jump into lung cancer screening. So we chose that this month because it's something that's near and dear to my heart. Part of my journey and part of my diagnosis story is that I, even sitting here as a stage 4 lung cancer patient, am still not a candidate for lung cancer screening, and I literally have the disease. So obviously there's some gaps in the criteria that are missing, and there's a lot of things that you've already kind of touched on a little bit that are holding people back from getting screening. So first question is, of course, what is the current criteria?
Okay, so current criteria just recently changed and back in 2022. At first, we're starting screening at 55 to 77. Recent, in 2022, we dropped down to 50 to 77. And then our pack years, meaning somebody that smoked a pack a day for 30 years, they'll be able to get screened. Now we dropped it down to 20. Okay, so it does include patients that are currently smoking or former smokers within the last 15 years. So they dropped it because we know we're missing a lot of patients. You know, we know people are getting diagnosed or smoking less. I know, especially with our African American communities, we don't capture a lot of things because we're only counting cigarettes, but then also the amount of cigarettes we're smoking mentholated cigarettes. So a lot of times what we're smoking is a lot stronger than the other cigarettes somebody else is smoking. So we know there are gaps, but we know that those adjustments definitely will help. Are we there yet? No. And like you said, we don't have any set protocols or anything for non-smokers. That still is not big discussion with the insurance companies, with the state, with just when we go out on advocacy about how we can get that started. I think we're far away from getting that done just because it took so long to get this done as far as screening patients who smoke.
Yeah. And I mean, I'm super biased because I am a non-smoker who has stage 4 lung cancer. So I'm like, we need to make it a priority. But of course, I mean, there's things that go into play when it comes to criteria. And I know that obviously it was originally, it was, I believe, 55 to 80 and then 30 pack years, like you said. Now it's down to 50 and 50 to 80 and 20 pack years. But what was, aside from missing people, was there some kind of process? I don't know if you can speak to this or not, but was there some kind of process to revise this criteria? And what, I guess, would it take to get a non-smoking criteria even discussed or even thought about? What are some things that could maybe, spark a fire, if you will?
Yeah, so when they had that discussion, they put the old decision and the criteria up, and they left it open up for comments, public comments. So there are different people and different advocacy groups across the nation that put their comments on how changing certain aspects of the guidelines would help them meet the criteria for our patients that we serve. So a lot of them, there were different things that were changed as far as even up to the radiology. We have radiologists that have to read. At first, they had to be chest radiologists, had to be certified. That changed to where they just had to be radiologists, but they have to read a certain amount. So little things, but it took, people making comments who work in this space, showing how, in their minds, it's a tiny little tweak. But if you're in a rural hospital and you don't have access to a chest radiologist, that means their patients are not getting screened because you don't have that access. So it took a lot of comments from different groups talking about how, we're missing gaps of patients who would never meet criteria because they're younger when they got diagnosed. So they would never be offered screening. So it took comments for them to actually come together and revise it.
So somebody, a loudmouth like myself, constantly talking about how bad screening criteria
Yeah.
needs to be amended for folks like me could potentially make the difference and tip the scales, is what you're saying.
Yeah, look, because we always feel like, is it falling on deaf ears? But even with, I made comments on it, but really, even with lung cancer being, the top killer when it comes to cancers, there were not enough comments. So that just shows, even with the impact that lung cancer has on the whole nation, we're still not at a point where enough people are involved in trying to change things, because we're making tiny little tweaks, but clearly it's not enough because too many people are dying.
Yeah. And I think that there's something to be considered too when you think about radiation, or not radiation, but radon and other risk factors, genetics and things like that. It's not just, smoking as a risk factor. Like, there are other things, environmental pollutants. I think New York is definitely part of the reason where my diagnosis came from, even though they can't tell me. But I mean, there's all these different ways that, our lungs are affected just by our air and our breathing quality and things like that. So knowing that that's happening, and knowing that there's all these environmental factors, you think that they would amend the criteria, at least to be like, hey, if you're in a densely populated area, like say in New York, or say, a California, or even, if we're going internationally, like Tokyo and those places where the air quality, they have alerts that are like, hey, this air quality is bad today. And it's like, what do I not go outside? What am I supposed to do when the air quality is bad? Like, you know what I mean? In those kinds of areas where those alerts even pop up, you would think that those would be populations that have a heavier focus on, lung cancer screening and lung health. And I just don't see that emphasis. It's always this smoking focus, where there's just so many more variables and aspects to this disease that they're missing. And it's so frustrating that, there just isn't a criteria for it, when it's so prevalent. And it is the number one cancer killer of men and women in the country.
Yep.
So it just doesn't get the math ain't mathin' when you look
It's
at
not.
it being number one. And then you bring into the idea, the fact that lung cancer is curable and treatable when you catch it at early stage 1, stage 2, you've got great odds of catching this early, cutting it out, irradiating it, and being done and being cured. But you just never seem to catch lung cancer until it's stage 3, stage 4, or later, where the cure is not there anymore. And there's just like, it just doesn't make any sense. It's like, if A plus B equals C, how are we getting Q?
Exactly. Look, you speeches to the choir.
I know, I really am. And it's I get on my soapbox and I start, so let me stop and get back to the point.
I mean, even with, the focus is like, oh, why are you guys, gung-ho? Because, I mean, some of the private payers, they will pay for patients that don't follow the guidelines. It takes a lot of documentation. They call it second guideline criteria. Radon exposure, heavy secondhand exposure, but it's really a fight to get that taken care of.
Yeah.
So that's why when people are like, why are you lobbying for Medicare to change their criteria, change their guidelines? Because when Medicare changed their guidelines, most of the other ones, they follow suit.
Yeah.
Because they're the biggest payer. So people are like, well, we got to get this. But no, when we fight for Medicare to change how they're seeing things and how they're changing their guidelines to meet the needs of the patients, we know that the other payers will change as well. So that's why a lot of times we're lobbying for them to look at how we can change things. Just changing it with the past few years shows that they're open and it's on their radar. It is a problem because, lung cancer, we don't get enough, you don't see people talking about lung cancer the way breast cancer is talked about, colon cancer, all the, treatments and all the walks and all the things that they're doing to change the way things are going. Lung cancer, we don't have the same
emphasis.
It's just awareness.
Yeah.
As the other cancers, and that's a problem.
It's a question that I have as well, because it's like, we all know at a certain age as women, you have to go get a mammogram. Like at a certain, like we dread it. We know it very well, but it's like we get to that age and we're like, all right, it's time to go get, a mammogram. And at a certain age, men know that they have to go get their prostate tested and stuff. And there are so many programs, and just there's just this emphasis around starting this process at a certain age for people. And you just don't have that same kind of criteria in the lung cancer realm. And I don't know why that is. I know it probably has something to do with, what age do you start? At what time, especially if we start to think about environmental factors and we start to think about, genetics and things like that, it becomes a question not so much of, who do we do? Because you're going to need to do everybody, but it's when do you start? Like, what is the date? Because even no matter what date we put down, we're going to miss people, and so
Yeah.
it's like, is there you know, a lesser of two evils where we find it an age that's like, all right, at age 25, you just start. But, then there's that, and we can talk through this in a second, but there's that idea of like false positives and scanning
Hmm.
people and screening people and having things pop up that may not be lung cancer, or putting people through unnecessary radiation and all that, which, as somebody who has stage 4 lung cancer, and really probably just needed a lung cancer screening when I first started exhibiting symptoms, I honestly feel like it would have been worth it. Like, if I had started getting screening at like 30 or something like that, they may have caught this at stage 1 or stage 1A or 1B or what have you. And I might be in a totally different situation right now. But the fact is, I have no history of cancer in my family that I know of.
Hmm.
Smoking wasn't really a risk factor for me because I didn't smoke. I mean, I did live in New York, and I always am like, in the back of my head, I'm like, radon
Yeah.
and buildings and pollution always plays a part of that. But the idea that, oh, the false positives and the risks outweigh the benefits. I think if you save at least one cancer patient, or if you find cancer in at least one patient, like that right there, you're saving somebody's life. And the more we keep saving individuals' lives like that, we move the needle forward. So I can't get behind the whole, like, the risk doesn't outweigh the positive, types of situations for me. That to me just doesn't make sense.
And to just be honest and frank, I mean, healthcare is a business as well.
Yeah.
So, what they're thinking about too, because you have to prove that, as much as we know screening saves lives, they always want more and more numbers. And the issue now, the patients that meet criteria, we still are not screening enough patients who actually meet those guidelines. And that's what's disheartening, because I know if we don't change that, other things are not going to change. As far
Hmm.
as adding, more patients that can be screened
Right.
without the factor of cost. Because can you be screened? Yes. But the issue is it's going to fall on you for the cost. There's already an issue with, payers taking care of certain parts of the screening, so having that met for the patients that actually meet guidelines now, it's important to get those numbers up,
Yeah.
because that's how we're going to show, like, hey, we're changing the way, lung cancer is headed. And it's already, the top cancer killer, and still we're not getting patients in to be screened the correct way.
Right. But it's like, isn't that part of the problem? You know what I mean? Like, obviously the money is a problem. That the fact that we have to even have this conversation with a money aspect or a money
Yeah.
focused issue. But it's like, at age 40, when I have to go get a mammogram, they're not going to say, well, have you had boobs all your life? Or have you know what I mean? Like, there's no other
I
criteria
know.
for getting a mammogram, but just hitting that age. That's it. It doesn't matter what else is going on in your life. No one's going to question you. So why isn't it the same with lung cancer?
And even the biggest thing with the lung cancer screening, a lot of patients, they get agitated when they call. It's not like the mammogram where they just put it in.
Yeah.
Lung cancer screening, you have to have a shared decision making visit. They have to document different things, so you're not showing any signs and symptoms, so that they talk to you about the risk benefits of getting the CT screening, letting you know that I'm talking about smoking cessation, because all patients that are going for screening are either current or former smoker. You have to talk about that. Have
Hmm.
to let them know, like, this is not just a get a scan and I'm done. You want to enroll them into the program so they know it is false positives that happen. You may have a biopsy and it might be nothing. These are just images. So you have to have that discussion. And that's one of the criteria
Yeah.
for them to pay for that screening is having that documented shared decision making visit. That does not happen with any of the other screenings. That does not need to occur.
Right.
But with lung cancer screening, which I explain to our patients, it's one of the criteria. We have to document it in order to order it. So that's one of the things that make lung cancer screening way more difficult, because it has to occur in order for it to happen.
Right. And so that we don't get too lost in the weeds of things that we both can't change right this moment, unfortunately, because I could talk all day about why the system is broken. But let's talk about the parts of the system that are actually working and why, we're still seeing some of these numbers. So I think I saw a statistic that said something along the lines of, in like 2022, only 4.5% of the people actually eligible to get screened for lung cancer went ahead and actually did it. So that number is obviously dismal for those, and those are folks that wouldn't even have to jump through the hoops to get, the approvals or anything like that. These are people who are qualified to actually be screened for lung cancer. Only 4.5% of those people are actually doing it. So why do you think that number is so low? And is there things that we can do to get that number up? Because I feel like maybe if we get that number higher, we can get, other criteria amended and stuff like that to catch other people too.
Definitely. I mean, it all starts with education. Number one, education of the patient. A lot of people, they don't know about screening. Why should I be screened? Because the first thing they say, well, I feel fine. Why should I go for a whole CT? Because X-ray sound way better than a CT. So it's just not getting that education. And to be honest, it's education of providers as well. A lot of times if they don't bring the discussion up, patients will never ask. And sometimes I even have patients who've had the screening before call me and ask me if I could tell their doctor, can you remind my doctor that I have to get another screening? Yeah. So it's that fear of having a discussion with the person that's supposed to be taking part in your care. Mm-hmm. That's a bigger discussion as well, because I want patients to you should be comfortable, should be able to speak about what you're going through. If talk freely about, smoking, other issues, then, it's a lot easier to get what you need done, including screening. So I try to just educate them. And then I always rally for providers to start that discussion. Don't assume anything, because a lot of assumptions are made. Oh, they won't want to do this. Oh, they'll say no. It's always better to ask until they say no. My mom tell me, you won't know until you ask. Right. So always, see if they want to. And some people, out of fear, I've had patients who even they go through the screening, comes back abnormal, then they decide they don't want to do anything further for a while. Out of fear, especially if you've had somebody in your family or know somebody, because in this day and age, cancer is so common that somebody,
or you are somebody.
So it's like it's not as far-fetched now to know or be personally affected by cancer. Yeah. So now it's that fear factor, and then that stigma because you smoke. So a lot of them, well, I did this to myself. I'm like, as human, we do a lot of things that
I could go on for days about smoking stigma.
But I'm like, I don't, want anybody to ever feel that way. Yeah. Be simple and just like, hey, just get it done, especially our African American males. Near and dear to my heart, because they're the ones dying a lot quicker. But I know from, taking care of them that they're harder to reach. Yeah. It's a lot of distrust in the system, past experiences, just needing to do everything else first. Yep. So
I know that story.
It's always hard taking care of them and reaching them, because it's a lot of relearning information, giving them new information, getting that support from outside resources, calling whoever I need to. So, I think it can be things can change, you know, but it'll always take some work, and we're working on it.
So is there any education? Obviously there is, but is there any sort of like conversation that goes on, I guess, in med school with doctors to say, hey, you need to, because like you said a couple of really amazing things just now. One is that, the doctors don't ask the patients. And it's like, okay, that seems like step number one. Like, how do we get the doctors more engaged in actually asking the patients about lung cancer screening and saying, hey, at least to the folks that are eligible, like you are within this criteria and you meet, the description. How do we get you signed up to get a lung cancer screening? Or can I get you signed up for that? Like, how do we start that conversation with doctors and make that part of their, bedside manner, if you will, like to start raising that awareness and having those conversations?
Because we work at a teaching hospital, what we try to do is when those fresh residents come in, try to meet with them, just general information, things you should know. And Dr. Fanon does a talk, goes to speak with them to kind of let them know why it's important. And then that relearning, we try to do a lot of pop-ups in the primary care clinic because I find that works better. Because, you got to catch them while they're in clinic. What questions do you have? Do you talk to your patients about screening?
Right.
Do you know how to document the smoking history? And a lot of times, it's little things like that can be answered in 1 minute that they would not stop to ask somebody else about. They'll just move on. Right. So we try to just always be available, just have that relearn, because there's a lot of things that residents are learning, fellows are learning. So just the active education, keep giving them that education via, email, tip sheets on how to order, and even, conversation starters. How do you start that conversation? Because, talking about smoking is not easy, because a lot of patients, they feel ashamed. If you don't approach them in the right way, they won't discuss how much they smoke. They'll hide how much they smoke. So it's just a lot that they have to learn about how to approach their patients to have that discussion about screening.
Yeah. And that seems like one of the first big hurdles that we have to jump over. Tanya Phillips checks in the chat. She's asking, what are options for uninsured patients if they qualify and want to get screened?
So I tell patients, like, as far as like at Grady, we have a patients assistance program. So most hospitals and even like different counties have money available to help with things like this. I always tell patients, you got to ask for a lot of things when it comes to assistance, where it be drugs, where it be like I had a patient that needed oxygen and they weren't forthcoming with the assistant programs available. So Grady, because Grady does get funding through the government, Fulton and DeKalb patients that live in those counties, they do qualify based on their income. They will have to bring some documentation to prove that they qualify, but then they have a set fee for anything that they need done at the hospital. They'll know exactly how much they'll be billed, or sometimes it's 0%.
Okay.
So I tell a patient, even if you're near another hospital, you want to know, just ask. Most places, they'll have a financial area that you can ask those questions. Don't be afraid to tap into your resources.
So for those folks who may be outside of the Atlanta region or maybe in a different healthcare system altogether, is there like a secret code word that's on the website? Like, is it like, something that if you want to find out if there's actually funding available at maybe your healthcare facility, but are not able to ask the doctors or anything like that? Is there like something on the website that we should look for?
I always do like financial assistance, but also the big search on the different website like Georgia Core. They're very good. They're really big on advocacy and different cancers, so not just lung cancer screening. They have a lot of resources.
Okay. I'm making notes on that. That is important information. Thank you, Tanya, for the question. 100% appreciate that. And I know there's folks out there that are probably curious as well. So, anybody else listening, again, we're live across Facebook and YouTube. So, if you have questions regarding lung cancer screening from wherever you may be, please feel free to drop a comment in here. And I will absolutely get that over to Ms. Dana Thomas, who is with Grady Memorial, nurse practitioner and subject matter expert on lung cancer screening with us tonight. Faith also checks in and says she called the doctor with a client today and asked her nurse if she could schedule a screening for her because she qualified. She said she would have the doctor order a screening for her, and it took 3 minutes on the line with the nurse. She said, "Is it really that easy, or did she just blow me off by saying she could make it get it scheduled that way?"
So when the order is placed in, especially initial order, that documentation has to be in place as far as, the pack years, signs and symptoms, that they had that discussion with you. So that's one of the things. If, with COVID, one of the good things that happened, even though COVID wasn't a good time, a lot of the televisits, video visits are now a big thing. Whereas before, Medicare was like, that's not allowed. You have to be an in-person visit. So we can do televisits or video visits to make that documentation. So that can happen quickly if it's arranged.
I guess, Faith, I would say make sure she follows up with those people to make sure that it actually did happen.
And like, you want to make sure it's documented, because that's the thing. When, they put in that authorization, it's easy to get that screening done, but you want to make sure that whoever your payer is, your insurance company, they have that documentation to show that it's a screening, so that you won't be charged like it's a diagnostic exam.
Awesome. Thank you so much for that information too. No problem. So I guess my question, and this is something I've been passionate about for a long time, and again, pie in the sky, I'm an idealist, if you will. One thing I would love to see happen is, and I don't know feasibility of this. Like, we can talk through what happens at a CT scan or a lung cancer screening, so we can go through that. But I would love to see like a mobile lung cancer screening truck at some of these events. Like, I don't understand why we can't have a truck that starts that, like just the way, Faith was talking about, she sat there with a nurse. Why can't we have a truck that's on site at these events to start getting people into these calls and into these schedules and things like that, just to start the process? Because I feel like that first obstacle is what keeps a lot of people from even starting the process, is just making that call or starting the conversation. So if we have somebody do it for us and get the ball rolling, sometimes we can keep it going ourselves.
I agree, because I know just like tiny tweaks, like having Saturday appointments, allowed a lot more patients to be screened.
Yeah.
And we know it's a possibility because we have CT. When we had different issues, we have CT on mobile units. So it's just setting up and logistics of getting it set up. And the thing is, we don't have a lot of state funding. Well, we don't have like the way breast does.
Yeah.
Because, a lot of the popular mobile mammography units are Georgia Public Health funding. And we don't have that for lung cancer. So I think those things need to change, because, hospital like Grady, where our funding, it's expensive to get a mobile unit. We need that backing from either private sources or government resources to get that done, because right now we don't have the backing.
You guys are right in the community that needs it too. So it's not like it would go unused. So, hey, people out there listening, if you have the connections to make that happen, this is what you need to be doing with it.
I know the Lung Cancer Roundtable, they've been asking for one. So I know, especially the more rural areas, they've been asking for one. They'll probably get it before we do.
As long as somebody's got it,
but I was like, look, we just need to show that, like, hey, like, it is a priority.
Yeah.
It's a priority as a nation to, shine the light on lung cancer and what it's doing. It's impacting so many people. So many people are dying. There's even a counter. I don't know what website. I don't know if it was a ACS website. There's a counter that you can change and see by every minute every week how many patients are being diagnosed with cancer. And yet,
I don't know that I want to look at that counter.
I
That's
know it's really
yeah,
eye-opening, but something like that needs to happen, so people understand that, cancer is not something so far-fetched. It's a discussion that's, needs to happen more frequently
yeah,
so that we can change things.
100%. So let's real quick, because I don't think we ever did. Let's break down some of the fear behind getting a actual lung cancer screening done. So can you talk through the process of what's required for that? Like what would somebody need to go through to get that lung cancer screening? What would that look like?
Okay, so you go to the doctor, you get checked in, you go in, because with that shared decision making visit, it can happen to any follow-up visit. So you have the discussion, give them your pack years, they talk to you about, make sure you're not having any symptoms like coughing up blood, losing weight, fever, chills, any of that. So they've kind of discussed with you, wanting to enroll in the program, talk about smoking cessation. So you have that visit, you go home. They schedule you for a CT scan. So people are always scared of a CT scan because a lot of times it's confused with the MRI machine. So,
Yeah.
the MRI machine, you're all enclosed and nobody likes to be enclosed. I've had an MRI before. It's not fun.
Nope, not at
So
all.
I always have to make clear to patients that it's not the MRI. You're not being enclosed. So you are laying on a table when you go in for your CT scan, and it does put you in a more donut hole. So the table does move you in, but it's not like you're enclosed in that area.
Yep.
So a lot of patients, they feel a lot better knowing that they're not going to be, I'm claustrophobic. I'm like, you're out.
Yeah.
Even our CT scanners, they're in big rooms, and now with the more advanced, they can play music. They are playing things for you to look at, but the scan is so quick. They make you raise your arms, and they'll take you to, like, take a deep breath in. They'll take the images. Honestly, it takes 5-10 minutes.
Yep.
But I tell patients, it's real quick. It doesn't hurt. A lot of the fears, like, it was like, oh, I can't, I'm scared, how much radiation. Well, it's a low dose for a reason. We give the lowest amount of radiation just for us to see. That's why they kind of make sure that you don't have anything active going on to where we have to give more radiation to see more. So it's really the lowest dose that we can give you to see the images that we need. And once they do the scan, those results go to me, and they'll also go to the doctor who ordered it, and then we'll both follow up on the results.
Okay. So is this different? So like me as a cancer patient, when I go for my CT scans, I think it's totally different because they're doing with contrast and without. Is a low dose CT, there's no contrast or
No
anything?
contrast. So no needles. No
What?
needles.
Okay. All
So
right.
they're always, I'm not gonna get hooked up to that stuff that make me itch. No. You get
Makes you
an
feel warm.
armband. Some people, they don't even change in the gown. I tell them, like, it makes it easy. Don't go with all your bling. Don't
Oh, yeah,
have,
every time I gotta take it all
they
off.
go with all the bling. I was like, leave it at home. Make it a lot easier.
Yep.
Wear something that doesn't have a lot of buttons or anything. And a lot of the times they won't even change you out. They'll make sure you just have an armband on, and they'll bring you in and get your CT scan. Make it easier for you. Because a lot of
So
people,
much
they want to
easier
be
than
in
I
and
thought.
out, right?
Oh my goodness. Okay, well, knowing that that's the process, like, there's no reason for anybody to be afraid of it. I go through the other process where I got to get an IV with contrast and everything. It makes you feel like you're peeing yourself.
Mm-hmm.
It makes you feel nauseous. It's like kind of tastes like pennies. Don't ask me why. I know what pennies taste like,
No,
but
you're right.
yeah, it's got like a real, iron
Metallic
taste
pit,
to it.
yep.
Yeah. So anyway, I digress. We're off topic. But yeah, absolutely. Now that we've kind of dispelled the fear a little bit of what a low dose CT is, what do we, I guess, or what are some of the misconceptions besides that there's pain and all that? Like, what are some of the other misconceptions that we can clear up about screening while we're here?
So a lot of times, like, especially if patients have had somebody that, quote unquote, had a spot in their lung, talking about a nodule, because we know that's one of the things, that's what we're looking for, nodules. And the education need to be done, because a lot of times, most people, if you scan them, they'll have nodules. But what it does when we do the screening, the radiologist is looking a different thing of the nodule. What size is it? What does it look like? Was it there before? Has it changed?
Mm-hmm.
Does it look like it's affecting the other parts of the lungs? So a lot of times, even especially if somebody has had a screening before and it was quote unquote negative, it was 1 or 2, and then they come back a couple years and they've been doing their screenings, and then all of a sudden it's a 4. They're like, well, I had a nodule and they didn't say anything about it. I was like, well, that's the thing, that's the reason why we do screenings, because we can track things, see if things change. Because we've had patients that had a small spot. It was 2 millimeters for years. And then all of a sudden, within that year, it went from 2 to 10. So just education about how things occur while we're doing it, the importance of getting something done every year. What happens after. A lot of patients not fear, if I do it, then what happens? Because that fear of lung cancer, what you hear when you associate lung cancer with death.
Yeah.
So a lot of them, they don't even want to get the screening because they don't want to know, because they feel, what are you going to do for me anyway? But I try to explain to them, we know screening changes things. If you catch things early, then you get way more treatment options available to you.
Yeah. And you're not just, I think a lot of people hear cancer and think immediately radiation and chemo. And it's not always that. I've never had radiation or chemo at all in my entire journey thus far. Fingers crossed it stays that way.
Yep.
But that's not always the answer to it. You know what I mean? Like, there's all these different treatments and different regimens now. There's immunotherapy, there's targeted therapies, there's all kinds of things where you don't have to actually get any chemo or radiation. So yeah, it's just getting over that initial fear that, like, oh, if I get screens, they're going to find something. Well, let's hope they don't. But would you rather not find something and have less chance to fight it? Or would you rather find something early and be able to potentially say, hey, I found it and got it taken care of?
Exactly. And also knowing that, somebody else's journey is not your journey.
Yeah.
A lot of patients, we do have to tell a lot of patients, because we work in a lung nodule clinic, we do have to tell a lot of patients their diagnosis. So, it's not easy, but, the reactions vary so drastically. And the biggest thing is, a lot of patients, they come in saying, when we let them know they have cancer, I don't want this, I don't want this, I don't want this. I'll never go to this doctor. I'll never have surgery. Chemo's gonna kill me. And, I just want to, because especially with Black patients, especially if you have stage 1 cancer, even with early stage cancers, we're least likely to have surgery. Yeah. And, and a lot, especially our older patients, a lot of them tell me once they cut into me that the cancer will spread. So they're that old, discussions that happen within the family that kind of continued on, that fear, like, oh, well, this is what's going to happen if I go to surgery. So a lot of times it's just that education, like, hey, even if I send you this for a consult for surgery, does not mean you're required to go to surgery. But I tell every patient, I at least want you to have that discussion.
Yeah.
Because I want you to even if in your mind that you tell me that surgery is not for you, you're never going to go to surgery.
Yeah.
I at least want you to have the education. I want you to hear from that surgeon what that surgery will entail, how, the risks, the benefits. I want you to go to every last one of the doctors and then make your decision.
Yeah.
And if then you still say that you do not want surgery, you do not want chemo, you do not want radiation, then that's fine. Because, I'm a firm believer, mind-body connection. If you're not on board, it's not good. You have to be on board with whatever treatment you decide to take for yourself.
Yeah.
But I was like, you need to get that education. Meet with the subject matter experts. Like, meet with the surgeon, meet with the one that's doing the radiation that can tell you exactly, what will happen, what their plan is, how it can help, risk benefits of everything, and ask your question. I tell when they go to those consultations, I tell them that friend, that family member that asks 1,000,001 questions, bring
Bring
them.
them.
Bring that person. The
Right.
person that you usually like, no, you stay in the car. That's that visit. You bring them in because that's the visit that you're gonna get that education, and then you'll make important decision. Because moving forward, that decision on what treatment you're gonna take is a very key one.
Yeah.
So I tell patients at least get the education first before you make that decision. Because a lot of them, oh well, my aunt had chemo, she didn't do well. 2 months after, she was so sick she wasn't walking around. But then, oh well, this person did good with radiation, so I'll take that. I don't want anything else.
Yeah.
So a lot of them is just based on hearing different experiences. But I tell them, like, we can tell you all the things and possible side effects. Honestly, we can never guess how your body is gonna react to anything,
Mm-hmm.
but we can tell you the facts that we do know about different things, and at least give you the education to make a sound decision.
Absolutely. So we're winding down. We got about maybe 10 minutes or so left in the conversation. And I would be remiss if I didn't at least bring this up as a part of the conversation, because it is important and it's so part of our culture now that it has to be sort of talked about. But this idea of hookah and vaping and how that's going to play into the screening criteria down the line, because how do you quantify that? I tried to look up like how many vapes is a cigarette and how many cigarettes are in a vape and all that kind of stuff. And it's like, when you start breaking down pack years, what if you vaped? What if you did hookah? What if you were, that kind of person? Do they have anything that they're working towards for that, or any conversation happening around vaping and hookah smoke that we can talk about?
We know that, especially vaping, is affecting young people. We've seen a lot of younger patients in the hospital with spontaneous pneumothorax, meaning their lungs just rupture, their injury to their lungs.
Okay.
So we know that these chemicals are affecting their lung tissue. They're affecting their lungs. We know this. But as far as, are we going to find a discrete way to quantify and actually make it a part of our education and documentation? I think we're far from it, because even, especially with our African American patients, they smoke a lot of cigars, cigarillos.
Black and mild.
Those are black and mild, the things that I've been wanting to document, because it makes a big difference.
Mm-hmm.
And that's why I know, especially with our African Americans, we're totally under showing how much, because they might smoke 2 cigarettes a day. But then when I ask them about black and milds, cigars, putting, I'm from St. Croix in the islands, they put tobacco
yeah.
in the marijuana. But
Yeah.
if you ask them if they smoke,
They'll say no.
they'll say no.
Yeah.
So I know, especially with the African American communities, we're already not counting a lot of the things that affect and will change their true smoking history, but it's not accounted for.
Yeah.
Because they're really just are focusing on cigarettes. But a lot of things is because studies in the past were not the major population that they're looking at.
Right.
We're not a part of a lot of the studies, and that's a bigger problem too.
Yeah. And I think a lot of the screening should be culture based, because smoking is different in a lot of different cultures. Like,
Yep.
there's cultures still out there to this day who, are very heavily smoked. Like, they smoke all the time, and it's, and it's not, I mean, cigarettes, like they really do. And so I think that there's something to be said for culture and environment in terms of the screening criteria. And when it comes to vaping and e-cigs and hookah and all that, it's gonna, with the younger generation they're targeting, because let's be honest, Skittle flavored vapes and like, cotton candy flavor things. That's child's, young
Yeah,
people flavors, like that's not, they're not targeting grown-ups with those. They're
they're
targeting those
not.
to look like candy for kids. And they're going to eventually skew the results because there's going to be, yeah, okay, 50 to 80 is the current age criteria for lung cancer screening. It's only a matter of time before that age drops drastically because you're going to start seeing a lot more, early 20s, early 30s and stuff like that. Young people who have been smoking, vaping and all that kind of stuff for years now in the doctor's offices having, like you said, these crazy lung situations that are brought about from these, the chemicals in these e-cigs and these vapes. And it's scary to think about
It is
because
scary.
we stopped big tobacco in a way. Smoking was down, cigarette smoking was down for a long time, and then they just had a resurgence with this
Yep.
vaping and e-cig where they found a sneaky little loophole to get back into the communities, and it's all our communities and it's young communities, and it's terrifying. Yeah, so I was like, I would be remiss if I didn't bring that up because it is such a part of the culture nowadays with kids just vaping and and thinking that it's better than cigarettes. That's
Yeah,
the
and
part
it's
that kills me
scary
is they're like, oh no,
because
I vape, it's better.
and
No.
it's scary because the nicotine content is
Yeah.
so crazy high that they're smoking so much and they're able to smoke, people that smoke cigarettes, they have to, try to go away. They try to have to move.
Yeah, you gotta like get off earth to smoke a cigarette now.
So but here, I was walking around the mall the other day and somebody was vaping in the mall, just
Yeah.
walking around and vaping. So it's more they're able to do it just readily anywhere
Yeah.
that it also feeds that addiction because that nicotine is so high in a lot of those vaping devices that they're just continuing to constantly use it, that I'm fearful of what's going to happen because it's only going to get worse,
Yeah.
especially the younger kids are starting to vape because they think it's cool. Imagine being 60 and addicted to vaping, and as you continue, you're only going to need more. You're going to be vaping more.
Yeah.
So it's just scary, the thought of what they're doing to our next generation. It's
Yeah.
scary.
And there's not a lot of people paying attention to it too. It's very sneaky how it's happening. And I'm like, ooh, okay.
And people know it's big business. So
Mhm.
before you know it, it never used to be the smoke shop, vape shops, the way I see it on
Right.
every corner now.
We're everywhere.
There's signs everywhere now. Everywhere I go, I'm like, there's a smoke shop here. There's a vape shop here. Like what? All
Right.
of a sudden, it's everywhere. So it makes, and I know a lot of these businesses are selling to young kids younger than they should.
Oh yeah. 100%.
So that's a big problem in itself too. But it occurs, and until they make it an issue, government makes it an issue, they're gonna continue to do it,
Mhm.
and that's sad.
Even worse. But we're winding down here. I just have one final question for you, and then give you an opportunity to share any last thoughts you may have with our audience today. What advice, if any, do you have for anybody who's newly diagnosed with lung cancer or who may have, just undergone a lung cancer screening recently?
For the newly diagnosed, I tell just be open to all the information that you're taking in, and ask about genetic molecular testing. Ask questions. Don't be afraid to, well, I don't want to ask. It might be a stupid question. I don't know if this is available to me. Ask questions. Get those tests run. I know a lot of people, when they hear molecular genetic testing, they get scared because they assume it's a study. They don't want to be a part. I tell patients, you want to know what treatments are available to you.
Yeah.
And the best way is to run different tests on the type of cancer you have and see what best your body will react to. So if it's available to you, definitely get it done.
Yeah. 100. I mean, I could speak from my own personal experience that if I didn't have biomarker testing, I'd be dead right now. Like I would not be here today. And I didn't know to ask for it. So I always make sure I tell people to ask for it and find out what it is and find out if you have a biomarker, because like you said, there are so many different medications out now that specifically just target that one gene that's a problem in your body. that you can take a medication every day rather than having to go to chemo or having to do radiation, which can destroy everything. It's kind of like you're blowing up your entire house to, kill an ant. And it's you're killing the ant, but you're also destroying everything else around you. Whereas targeted therapy is like, slingshotting the ant and it's not necessarily hitting everything else in your house. You may break a vase or two, but you're doing a lot better. So that happened because of biomarker testing. And if they had just thrown me into chemo or radiation to try to treat when I came in with my symptoms, it wouldn't have worked for me. It wouldn't have worked for me at all. And I probably wouldn't be here today having this conversation. So genetic testing and biomarker testing is important. There's nothing to be scared about for it. It's just going to help you make more informed decisions about your healthcare decisions. Like you have way more treatment options when you go through that testing because it's going to tell you what's truly going on with your cancer and what may actually work for you in lieu of chemo and radiation.
Very good. You know best, right? Hear from you how it's helped. And that's important.
Some people have to just hear it from somebody who's had it
before,
definitely, just to learn.
Definitely.
Yep. And it didn't hurt. Nothing happened. They tested the samples that they had already taken from me and ran it through some molecular testing, and that was it. And then I had a decision from there. And so it was a lot easier. It was almost, I didn't even know what happened until it was done. And they're like, oh, we did this and this is what happened. And I was like, okay, great.
The more we use it now, there's, blood testing because we, do a lot of tissue. So more companies are knowing that like, hey, this is needed. Let's figure out how to do this more efficiently, and it helps with the cost. The more time we get this done and they do more research, it's going to help more patients.
100%. Well, Dana, thank you so much for your time tonight. I really appreciate it. I want to give you an opportunity to maybe shout out your contact information if anybody's interested in continuing this conversation with you or maybe asking you additional questions after we wrap. But also if there's any final words that you want to give to the audience tonight, I want to turn the floor over to you and allow you to just speak to your listeners.
Yes. So if anybody wants to email me, please feel free to email me at djthomas@gmh.edu. Final words, I want to, let patients out there know, lung cancer is not a death sentence. We know that screening changes things. So we'll always be advocates for getting screening done. And, we just know getting it done early is going to make a big difference. But we know that it's not the same as it was years ago. There are a lot of different treatments available that makes a difference with your outcomes.
100%. Well, I want to thank you again for your time tonight. Folks, thank you for tuning in across platforms, YouTube, Facebook, anybody who's listening, anybody who catches the rebroadcast of this episode. Thank you so much for being here. This is not the last one of these. We're going to have one every single month. So make sure if you have questions and if you have things that you want to ask, make sure you reach out. This is your opportunity to talk to the subject matter experts in the lung cancer field. And I am very happy to be a part of this conversation every time it happens. So again, thank you everybody for tuning in. If you have any additional things you want to say, the chat will still be live on these conversations. Feel free to tag us and ask more questions, and we are happy to continue the call. So thanks everyone. Have a good night. Make sure you go watch the debate. I know everyone's waiting to go do that.
You, Jamie. Appreciate you.
All right, everyone be safe.